My name is Dr. Mutua Mbuvi. I wanted to thank you all for joining us today morning for this EM talks. And the emergency care talks is something we host every month. Preferably, it's really the last Saturday of the month, but we had to do it on this first Saturday of this month due to some delays in some few things we were getting ready. But well, it's here, it's today, and we are about to get started. So as we're here, so you guys know that EMKF is a not-for-profit organization, and this is what we usually do in our quest to ensure that we have timely, accessible, and quality life-saving emergency care in Kenya. That's our mission. That's our goal. That's what we are targeting. And the EM talks have been there, and we usually discuss many aspects of what we do as in regards to emergency care in Kenya. We have a lot of discussions in regards to trauma, in regards to the healthcare policies and things like that. But today we wanted to have a look from a different perspective. From one of the recent meetings that was held where Dr. Washira was presenting, he said something that actually stuck with me. He said that the patients who come to us in the emergency department, these people did not want to be there. They had not planned to be in the emergency department on that particular day. These are regular, ordinary people who probably were just heading to work, and then the next thing you know, they end up in our emergency department. It was not something they had planned for. It was not a routine doctor's visit. It's just something, an emergency occurred, and they had to land in our facility. And we go about and we do our best to save their lives and to do what we need to do. But we also, sometimes we tend to forget to look at the other aspect of emergency care. This is in regards to the psychological aspect of emergency care. Therefore, today, I am honored to have Susan Ruturi. Susan Ruturi is one of the nursing, part of the nursing team that we work with at KNH Accident and Emergency Department. But Susan's work is different from what the rest of us do. So Susan is a clinical psychologist with a bias in addiction education, prevention, and treatment. But just apart from being a clinical psychologist, she is also an emergency room trained nurse who also has basic EMT training. And previously or formerly, she has been a trainer for the basic life support, for the advanced cardiac life support, pediatric advanced life support, and basic and BTLS. So this is someone who understands the concepts of emergency care very well. And now today she'll be here to give us a discussion on how to look at the psychological aspect of emergency care. This is in regards to our patients. This is in regards to us as the clinicians who are dealing with these patients. And this is in regards to the relatives and the next of kin who come with these patients when we need to talk to them about what is happening and what is going on. So without much further ado, I would like to welcome Susan Ruturi to share her screen and take us through this presentation. And after this presentation, we will have a general discussion into what emergency care, what mental health in emergency care is all about. And I'll invite you to, you can put your questions into the chat area if you want then, but you still, if you want to ask a question at the end of this presentation, you can just raise your hand, and then I'll give you an opportunity to ask your question, and then we can make this session as interactive as possible. So, Susan, the floor is yours.
Okay, thank you, Dr. Mutua. Good morning, everyone. Yeah, we're going to talk about mental health in the emergency care services. I know Dr. Mutua has explained in much detail about what we're going to do. However, my concentration is going to be about raising awareness about mental health in the emergency care facility, environment. And we'll be sensitizing ourselves on the common mental health issues concerning individuals working in the emergency room and the pre-hospital care situations. Now, mental health is a wide topic. When I got this invitation, the thought that went through my mind was, do we understand ourselves as mental health as emergency providers? When I say emergency providers, is the emergency room workers and the pre-hospital care worker providers. Do we understand ourselves? So most of it will be about us. I will mention maybe a slide or two on what to deal with the patients. Also, I want to bring to your attention that almost every slide can be a topic on its own. So there is a lot that I will leave out since it is just raising awareness. I hope you will invite mental health specialists, other mental health specialists, to come and give detail on every other slide that I will present. You can also probably just write down what are some of the sections that you felt, oh, this really, I wish it was brought up in detail, so that probably you can forward to Dr. Mutua and anyone else who is in your leadership, so that it can be, we can concentrate on specific things that you're interested in. So to allow me to take a breather, let's take an activity. Let's do an activity. And the activity we are going to do, before I talk about the activity, we are going to have a lot of interaction. Hopefully, sometimes I forget, but I'll try as much as possible to allow us to interact. So keep your unmute button ready so that you can speak back to me, and so that we can have a conversation. So we can now turn on our unmute button and discuss. What are some of the descriptions you can use on yourself? No, let's say one description you can use on yourself that is associated with improving somebody's mental health. What is good about you? What is your personality, or what is the many terms that people would use, but what is your strength that can improve somebody else's mental health? So an example, probably I would say, somebody would say they are caring. So that's just a characteristic of somebody that can help someone else feel taken care of. So I invite in comments. Unmute yourselves. I hope, Dr. Mutua, it's possible to unmute ourselves.
Yes, it is. You can unmute here.
Okay. So yeah. Let's hear. We are just 14, 15, getting to 20. So at least 2 or 3 of us can speak. What are some of your strengths? Can I call on names?
Yeah, you can. Let's make this interactive. Call on people's names. They open up.
Jeremy, I hope you can. Okay, I see like Noor is ready to speak. Noor, are you ready to say something? Oh, she disappeared? Okay, Jeremy Kitome.
Yes.
Kindly say something.
Maybe.
What is your strength?
I'm able to lend ear to listen.
Okay, you're good at listening. Excellent. Any other examples? Somebody else? Those who are logging in, we are trying to identify our strengths that can improve somebody else's mental well-being. Maureen Mumo, tell us something kindly. Followed by Lynn Kagia. Say something. One of your strengths. What are your strengths? David, do you want to say something, Moteti?
Yes, good morning. I think I have a strength in. You can all hear me, huh?
Yes, we can, David.
Yes, we can.
I think lending a ear is very important because it itself is a therapy, like trying to listen to that person, even if you're not going to say anything, it will mean a lot.
Okay, great. Okay, I don't know whether people are not able to unmute. Thank you very much, David. Or is it that they are not ready to respond at this time? But I hope with time we'll be able to have further conversation.
Heather, good morning.
Good morning, Kagia.
Morning, fellow colleagues. Sorry, I was still just in the process of logging in.
Sorry.
But yes, so I think one of my strengths is that I'm a good team player. And I feel like I also have a good listening ear.
Okay.
You know, sometimes in our field, you just need somebody to listen to you and you feel appreciated.
Wow.
Back to you.
Thank you. Thank you very much, Kagia. So these are some of the things we'd like to raise to your awareness on some of the characteristics as healthcare workers that we would want to emulate or would want to use while we are in the environment of emergency care to ensure that we take care of our own mental health well-being, take care of our colleagues, and when we meet patients, we attend to our patients rightly. So as I mentioned earlier, I think I have prepared myself more for ourselves rather than how we will deal with our patients. I know I have a slide or two on how we will deal with our patients, but my main concern when I was told about mental health in the emergency services, I would just want to, again, I want to reiterate that it is raising awareness, and then hopefully with time, you guys can invite people from the mental health environment to come and talk more about it. So my objective would be, or what I hope we will go through would be understanding mental health, understanding the interlink. Why is mental health important to us as emergency people in the emergency services? We'll see what are some of the workplace hazards associated with that can affect our mental health well-being, and then we identify how we can recognize individuals who may have mental illness. And I want to say this early, since you're not mental health professionals, what you recognize, you can raise that concern with either the individual, if you're comfortable with that individual, or with your manager. And I'll mention some of the things that you may notice. And you're not making a diagnosis, you're not a mental health specialist or trainee, or you're not qualified in mental health. So ours would be, as emergency service providers, is to recognize some of the symptoms and then take action so that we can ensure our workplace is safe. And then we'll outline some of the strategies that will enhance mental health amongst us in the emergency services. So what is mental health? Mental health is defined, I'll read it as it is from World Health Organization, is defined as a state of well-being in which every individual realizes their own potential, can cope with normal life stresses, can work productively and fruitfully, can make contribution in their community. So all these things can should be present in order for us to describe the individual as having good mental health. So if they don't have good mental health, then we need to have noticed that so that we can bring them back to mental healthness or wellness. The first director of WHO also added that without mental health, there is no true physical health. So we must ensure that there is complete health, mental healthness, complete mental wellness, so that we can be able to say that we are completely healthy. So let us not ignore the mental health perspective. If individuals have mental illness, we must ensure that we attend to that so that they can be able to be physically healthy. How is mental health associated with us in the mental health services? So let's first say that mental well-being is the ability to effectively deal with activities and stresses of daily living. So if we can effectively deal with it, then we are healthy. But then, as emergency service providers, we are often exposed to stressful situations. Our patients, we can't say like every other 30 minutes we will have a patient. Our patient inflow, either you're at the ambulance, you can be called anytime. You pick your plate of food you want to start eating, you're called to go for an emergency. You maybe be walking away to go and take a tea break or a healthy break in the emergency room. You realize that you've been called to deal with a resuscitation. So our flow in emergency services is undefined, erratic, and evidently our patients are very traumatic, and some of them are gravely ill, and that can cause us to experience critical incidences. So what is a critical incidence? Let me hear it from us. So what would we say is critical incidence? Comments from members?
Anyone with a comment can just unmute and just give us an opinion. Remember, this is a discussion. We're not here to, there's never a wrong answer, especially when it's about adult education and things like that. There's no wrong answer. So anything, any idea that you have in regards to critical incidences, just anyone, just unmute and let us know what you think.
Ernesto Fiambo, kindly allow me to call on you. Okay, Helen. Helen, would you like to say what is critical incidences? Wow.
Good morning, everyone.
Wow, okay, thank you.
The challenge is trying to unmute the system. I don't know whether it's only from my side or everyone else. But I got your question. I think critical incident is any event that has an impact on the activities that you're doing, basically.
Okay, so it's any incidents. And so as emergency healthcare providers, we are exposed to critical incidences. And when these incidences occur, they can raise certain reactions. One of the reactions would be emotional, that will get shocked. we will have cognitive challenges or cognitive reaction. That would be, an example would be like erratic decision making, and maybe behavioral, that it affects how we behave in the workplace. So I'm wondering, have we been in such a situation where you go into an emergency and you feel you get yourself in a situation where you're feeling shocked, or you are afraid of what you're going to do? Oh no, let me say somebody else has somebody, so that we don't feel like, oh, us guys, so-and-so said that they're usually shocked when they go to their field. So probably we might talk to our bosses and tell them to get them out of the system. But then let's say, how have you seen somebody making decisions that you're wondering, hey, what's happening to this guy? Have you observed any of these characteristics, reactions, emotional, cognitive, behavioral? Waiting for examples. I hear there's a problem with unmuting, so I'll give a minute or two. Anyone can speak kindly.
Actually, I've sorted out the unmuting thing. The settings is now that anyone who wants to speak can just unmute themselves, and then they can give their comment, and then they can mute themselves again once they're done. Yeah, but maybe if I can answer, I've actually noticed some of these emotional, cognitive, and behavioral reactions, especially in our emergency department, because we do get some very, very, very critical cases, and sometimes the virtue of seeing the patient in the state that they are in, actually, number one, does cause emotional shock, because at that time you're wondering, okay, how is this person still alive? How are they still breathing after whatever they have gone through? And then the cognitive one, the erratic decision making, is when now you have so many things in, or there's an overwhelming incident where you have multiple patients who have come in and all of them have serious injuries. You're trying to figure out, okay, who do I start with? Who do I, this person needs blood, this person needs this person needs that. So you end up having this very erratic decision making that sometimes can lead to poor management of our clientele, of our patients. Yeah, and behavioral in regards to poor interest in work. Yeah, well, I haven't seen that one yet, but maybe. So anyone else who can tell us about their experience in regards to critical incidences, just unmute yourself and let us know.
Okay. Guys, kindly be ready to unmute yourself. I'll be asking a lot of questions because I don't want us to have a lecture. I'm hoping we can have a lot of discussion. So kindly look for your unmute button so that you can use it in time. I'm hoping that most of us will have spoken by the time we finish. So thank you, Dr. Mutua, for that example about how people can react when they face a critical incident. And so these things, when we go through that, it stresses us. It stresses our mind. It stresses our well-being. And so it is important for us to realize that critical incidents, the environment that we work in, it requires mental health intervention. So you must have mental health activities in your work environment so as to ensure we take care of the stressors that come in due to or come around due to the critical incidents, since often that is what we deal with. And I want to bring to our attention that CDC has flagged mental health. So it's something that possibly soon we'll be seeing that we must have policies on mental health in the workplace so that individuals can be safe in the workplace. So what are some of the hazards? Once again, let's discuss. You can even use the examples that are on the screen. What are some of the hazards that we experience as emergency care providers? Kindly let's speak with one another. What are some of the hazards you have experienced in the workplace?
Bad relatives.
Wild relatives, okay. Was that Jeremy Kidomi or
Yeah. Yeah.
Zioki, you can go ahead.
Fights, physical entertainment.
Thank you, Jeremy. The two Jeremys. Helen, go ahead.
Exposure to diseases or infection.
Especially during this season of COVID, we can easily be
due to maybe insufficient PPEs or something. Yeah.
These are things that can cause us stress. Anyone else?
Yeah, sometimes you find you are dealing with patients who are not ready to comply, like in these COVID protocols. Like you're telling somebody to put on the mask, but they are reluctant. Some other people come drunk, so they are not even ready to listen to what you're saying to them. So it comes out like an hazard.
All right, excellent examples. Other examples are even our personal experiences outside the workplace. So we would find ourselves in a situation where you've left home, probably if you have a child, you've left your child unwell, but you must go to attend to an emergency because that's what you signed up for, to deal with emergencies. So you may find yourself unsettled when you're in the workplace, and that is in itself a hazard. Media, how often do we hear praise reports about emergency services? How often do we hear praise reports? Especially in the pre-hospital care management, do you hear it a lot? Grace, do you hear any positive reports about pre-hospital care or care in the emergency room?
Hi, good morning.
Morning, Grace.
Yes, I have had.
Yes.
But more often than not, it is negative.
Yes.
Where you hear people saying ambulances are, after all, not carrying any patients. Maybe they're just selling drugs or the relatives to the people who man them. So, yeah, I have had those cases. But maybe I should also talk about one of the hazards that I have come across in the A&E.
Go ahead.
And that would be a patient carrying a firearm and he is violent, or maybe not even violent, but the sight of it makes me very, very anxious. Yes, I have also received a patient who has declared that he has shot the patient he brought in, and you're thinking, suppose he shot me too. Yeah.
Yeah. Thank you for those examples. Yeah, being in the emergency care, there are many things that can stress us. So one other thing probably I was hoping somebody would mention is our sleep patterns. The fact that our work environment is stressful, there are times that we start replaying what we saw or rethinking what we saw in the workplace. So we find ourselves, when we go to sleep, we are not able to sleep. But also our work schedule, it's not an office kind of schedule. We work in shifts, and so it disrupts our sleep patterns. And so that in itself is a work hazard. And so we want to be aware that when we have sleep disruptions, we want to take care of that so that we, especially when it is manageable, we want to ensure that we take care of it. Of course, we can't change our working hours. So if we can't change our working hours, what must we do? When we get to sleep, ensure that you rest and sleep, not being in a situation where you're always alert. So ensure when you get to sleep, you sleep well, and good sleep is a sleep that we call REM sleep. This allows our brain and our mental health to be rejuvenated. So it's important for us to ensure that when we get to sleep, even though our working hours are not normal, quote unquote, we ensure that when we get to sleep, we sleep well so that we can have a good rest, night rest. So I had mentioned that I would say something about the patients. Some of the patients that we receive may be suicidal or had a suicidal incident. Some are neurotic, have anxiety. Somebody mentioned about being intoxicated. So when we receive this kind of patients, what should you do? Ensure your safety first. Even when we are doing the ABC, one of the things, the first thing we do is ensure safety. So even when we have a patient with psychiatric illnesses, ensure your safety. Then assess that patient to confirm whether they are actually whether they're actually mentally ill or they have a psychiatric illness, or is it somebody who is just being stubborn? And so their attentions will be different, because if somebody is just being uncooperative, then it will be a security issue. But if it's a psychiatric illness, then you want to attend to it as a medical person or a health care provider. Then once you have assessed the patient, confirm with the others around. Sometimes it's possible there could be somebody around who may tell you, oh, this is what happens to him when he doesn't take his medicine, or this is how he is when he's drunk, if I could use that as a common term, but in mental health we have different terminologies. So once you know that, then you are approaching the patient with information. Now you'd want to consult from your manager or your team leader or whoever it is on what intervention, that's what we are calling consult. What intervention should you do? Are you allowed to restrain this patient? Are you allowed to provide medication? Are you allowed to just observe the patient and somebody else to come and attend to the patient? What's usually your management process in the workplace? So I stands for immediate care, which many times would be pharmacological. And then you transfer the patient. Ensure that you consult the caregiver on where to transfer that patient to, and let them know why you're transferring them, because sometimes they may say, oh, this one is just intoxicated, achaneni na yeye. But then you may realize that, and once again, I had said earlier that some of these things can be a full CME on its own. So like if it's somebody who is intoxicated and they're usually like that, this is somebody who may need to be in a mental health area, rather than being probably taken to a home or being taken to prison, or no, not to the prison, to the police cells because they are being unruly. So it's important to let the relatives know why you're transferring them. And then there is a new thing about involuntary admission. I just want to bring to your attention that involuntary admission is one of the things that is being discussed a lot in the mental health field, whether if patients are mentally ill or have psychiatric illnesses, we can take them to the mental health hospital, not the regular hospital. Like say, for instance, if I find a patient with mental health, psychiatric illnesses, should I take them to Mathare or should I take them to maybe Aga Khan Hospital, Kenyatta Hospital? So there is a discussion about involuntary admission to mental health care. And so when you have another invitation, probably somebody can discuss that so that you are not sued as an institution. Then other issues you'd want to concern yourself with if you're in the emergency care environment is patients who constantly come with similar symptoms over and over again, and yet they have no, their labs, when you do the labs, they are negative for anything. When you do x-rays, CT scans are normal, everything is normal. You may want to consider mental health care so that the individual can be productive. We say that individuals with mental health should be productive in the society. So if somebody is constantly coming to hospital, it means either they're not taking care of their children or they are not reporting to work, and so they are unproductive. And so that we can help one another to be productive, it's possibly important to refer these individuals to mental health care. Now, somebody had mentioned that patients, relatives may be uncooperative. One even mentioned that, I think it was Grace who mentioned that one had shot another. So, but in a normal situation, our patients, our relatives are in panic. It's an unusual experience. It's a sudden experience. It's not like probably somebody who has, what example would I give? Like an expectant woman who is due for delivery. She was anticipating. So chances are her level of panic is lower if it's a term pregnancy. I'm not talking about the earlier ones, but term pregnancy. This is somebody whose panic level may be lower than somebody who's had an accident. Isn't that so? I hope it's a yes. So sometimes our patients are very anxious and impatient. They want their patient to be attended to immediately. We really think about everyone else around us. We want our patient is the sickest of all the patients that are there. So we find our patients being very impatient. So what would we do? Ensure that you respond to them calmly and respectively so that we do not agitate them. So things like in the emergency room where we would say, tuko na wagonjwa wengi, that is not anything important to them. Them, they know they brought a patient, not they brought all these patients. So it's important that when we respond to them, we respond to them in a way that would encourage them to be calm. So being in such situations, what would happen? We would be stressed. And stress can be good and can be bad. I would have allowed us to discuss and see whether stress is good or bad. But let me say that stress can be good or bad. Like, say, for instance, if good stress would be like if you came across an animal, dangerous animal, your stress levels will go up. You will have fight, fright, or freeze situation. So if you choose to take whatever option you choose to take, it will be for your own good, to ensure that you're safe. If it's a lion, stay quiet. If it's a snake, you want to run. If you know, it is good. It's optimal performance where we know that you're going to do well. But then also, if you're not active, it can be stressful. It can cause boredom, which can also be a situation where we move to the other side where we get strained and we get burnout because we are overwhelmed. And so I'll move on to burnout. I did a study last year where Ruturi is I. I did a study last year and found that 59 of our healthcare workers have moderate or high burnout. And I would say what burnout is in a short while. Probably in the emergency, in the pre-hospital care, it could be higher. According to the studies that I have gone through, the burnout levels are usually higher because of the movement, because of the noise, because of the sudden, you see, like for us in the emergency care room, would have people whom the pre-hospital people may have taken care of them. So our levels of burnout may be lower because we are dealing with people who may have relaxed a little because the initial care has been provided. So sometimes there's that argument that possibly the pre-hospital people may have a high burnout, but the high burnout is because we haven't attended to it, and we will see how we can attend to burnout. So what is burnout? Sometimes burnout is ignored. And I want to use the example of a toad in a boiling pot. Anyone has heard about that and tell us what it is about? Anyone can tell us? Even Dr. Mutua, you can also tell us if you've heard about the story. Any of us can tell us. If you've heard the story, yes.
Yes, we have heard that story. So apparently, is a toad or a frog that is it's in a pot, and this pot has water, and then it's put like this heat underneath, so the water is slowly boiling. But the toad stays in that water trying to figure out when is the perfect time for me to jump out, or when is it going to be like really, like boiling enough for me to know that I need to jump out. Eventually, the toad stays there far too long and ends up dying.
Thank you, Doc. So that's what happens with us. Let me just tweak it a little. That if you put a frog in water, in boiling water, they will possibly jump out. However, if you want that toad to stay in the boiling water, you put it in cold water, it will feel comfortable. And the temperature, you can continue increasing the temperature. And at the end of the day, like Dr. Mutua is saying, you'll find the patient, the toad staying in the boiling water. That's what happens in burnout. We sometimes feel so comfortable with the stressors. We feel this is normal, or we feel like, oh, we are medical health providers or emergency health providers. It is normal for us to be stressed. It is normal for us to be anxious. No, it is not normal. We must ensure that our health being is, mental health being is constantly addressed. So, burnout is such an important issue that even the WHO has now described it. Previously, it was not noted as an important thing in mental health, but ICD is process international classification of diseases, how we classify diseases into groups and into common symptoms. And so WHO has now put in burnout as one of the issues, phenomenon that we need to pay attention to. So as I had mentioned earlier, it is something we need to take care of. So how do you know that you have burnout? I'll say in brief that it is what I had mentioned earlier, that it is emotional exhaustion. You are always depleted. You're going to work, you don't feel like working. Depersonalization, the DP is depersonalization. You are indifferent. You see a patient, like say for instance, I think an example is you see a patient delivering, you're like, sialijua na ataza. Why did she not go to hospital in good time? Others are totally always negative. You have no interest in anything that is said. Like we say, for instance, we start being given KN95. You are negative about KN95. You want N95. So we are always negative if you have depersonalization. And finally, PA stands for a reduced sense of personal accomplishment. This is usually at the end. Once we have emotional exhaustion, once we have depersonalization, then you begin to feel like I am not worth, I don't have worth in the workplace, I'm not interested. And then you start not having a feeling of success. And how probably you'd see this is like you have successfully transferred a patient from point A to point B. You begin seeing, oh no, I shouldn't have taken that route to get to the healthcare situation. I should have used a different route to get there. You start giving negative feedback to yourself. So you devalue yourself. You're not interested in being appreciating yourself. So when these things begin to happen, and they creep in very slowly, like the example of the frog that we have said, we are put in cold water. And then it starts getting warm, until at the end we realize that we can't handle it. We shouldn't allow that to happen as healthcare providers. If you're feeling that your partner in the workplace is always indifferent, so raise it up with them, or raise it up with your manager, so that we can take care of their mental health well-being. So the Samaritan syndrome is one of the symptoms that you may find in an individual that has burnout. They are always working. All shifts, they want to be there. Their shift is over. They hear that the next person is not coming to work. They say, no, I can extend and all that. So you find yourself being overly available to assist your manager, but then you're getting yourself into burnout. So I wanted to raise this as a concern, so that you can be careful about instructing people to take over extra duties, or if you are the one being instructed, you're being supervised by a manager who keeps reaching out to you. You want to raise a concern with them and see whether there's a way you can be allowed to take a break after, for instance, you respond to an emergency situation, or possibly is there somebody else who can take it up. So we don't want to have Samaritan syndrome in our midst, because if we do, then we will be experiencing burnout. So are there any comments so far? Any comments so far? We've been talking for about an hour. We are getting to discussing about common manifestations. Any comments so far? May I invite Anne Courier? Anne Courier, do you have any comments so far? If you can unmute yourself and comfortable to speak.
No comment, but good presentation.
Thank you, Anne. Okay, so let me move on to common manifestations of mental health issues. So anyone can experience emotional distress. Your manager can experience emotional distress. A long-term experienced pre-hospital provider can experience mental illness or emotional distress. It is not it is not a sign of weakness. It is just that their mental capability has been overstretched, and it can be overstretched by poor management of our mental health situations, or because of the work environment, and I'll mention about that in a few minutes. So some of the common ones are acute ASDs, acute stress disorders, usually brought together with PTSD. It's usually combined in general communication, but in the mental health specialists, they can significantly differentiate the two. But I want to just say that this usually follows experiencing or witnessing a stressful event or terrifying event. And it can, please note, experiencing or witnessing. And witnessing is also a very stressful situation. It's something that doesn't get out of our mind. So when we observe, when we go to offer maybe services in an emergency situation, just the fact that you are not in that emergency, you're not the one who experienced it. It's not the experience of the patient. But now as a healthcare provider, it can lead you to experience some mental health illnesses, which we are calling one of them we are calling is PTSD. So how do you recognize that? There's re-experiencing. You're feeling like you're back to that situation. Hypervigilance, where you're always careful of any situations, or avoidance. We don't want to talk about that incident. You don't want to write the report about that incident. When we are having meetings related to probably how to deal with emergencies in a building that has collapsed, you don't want to be invited in those meetings. So you are always avoiding, if that's how you had experienced or witnessed the event, then you want to avoid anything related to that event. So the other thing we find common and easily ignored is depression. Depression is a terminology that we throw around, but it's a very overwhelming experience where the individual is totally disinterested in, they have no interest in anything in life. They don't clean themselves, they come to work, they are not as smart as they used to be. A lady who used to probably use makeup, they have reduced use of makeup, they're just using the basic makeup, and they're hopeless. And being hopeless can be a very depressing, or let me not use the same terminology, can be a very overwhelming experience. So that's another example. Another manifestation is anxiety. You find that people are restless, always nervous when they experience mental health issues. Another manifestation is substance use. Coming to work intoxicated is a mental health issue. So if you have a colleague who comes to work intoxicated, they could possibly be experiencing a psychosocial disease, and we need to attend to them as individuals who need mental health care rather than any other thing. We should not allow them to take their leave days of that when they're intoxicated. They need mental health care. Another one is self-harm and suicidal ideation is common amongst us, because sometimes we feel we have taken care of so many people. They're always, possibly we get very negative outcomes, and so we begin to feel like we are not useful, we are not helpful. So we could possibly experience self-harm and suicidal ideation. Some of the examples that you may experience or you may see in people who have suicidal ideation, they may give threats. And a statement you may hear somebody saying is, Najiskia, I think I'll die. And sometimes we play around with that word. Like, say, for instance, we are talking about what example would I give? But we use I will die very easily. But sometimes we want to pay attention to what the circumstances are. Where did the person bring that statement about? Is it a common, a regular conversation, or is it really that the person is explaining something or experiencing something? So let's not ignore some of these words, and we will do a little exercise to see whether we have gone through some statements where people have said something and possibly may have been a suicidal threat. So as mentioned earlier, common manifestation is personal extreme psychosocial stressors. We get sick as healthcare providers. We get sick as emergency room providers, pre-hospital care. We can get sick, so we are not immune to illness, and so we need to be attended to appropriately. I see, Joanne, you have unmuted yourself. Do you want to say something, or was that by mistake? Okay, you've muted yourself. Okay, so let's see this. Which of these is a myth and which one is a fact? And once again, we want to speak with one another. So the first one is, people who talk about suicide do not actually commit suicide. Is that a myth or a fact? Let's speak to one another.
Myth.
Myth. Yeah. Thank you, Grace and Jeremy. Yes, it is a myth. Incidentally, 80%, that's what I discovered in this, the link at the bottom, that 80% of individuals who say they want to commit suicide, either by, they want to die by suicide, either by saying it or directly, or saying that they are not interested in living again and things like that, chances are they will attempt or even successfully die by suicide. The second one, a suicidal person will commit the fact if he talks about his suicidal feelings to another person. So is it a secret to, is it a myth or a fact? If people, if a person who wants to die by suicide speaks about it?
I think that is a myth, because most of the time if they talk about it, then they will get help most of the time if they talk about their feelings to someone else.
Okay, I agree. If you disagree, please raise concern, and then we can see how we will work with it. Thank you. The other one is, all suicidal people want to die. They want to die. And there is nothing anyone can do about their death wish. I think that indirectly Ernest has answered, so we will move on and say that is a myth, right? If you think it's a fact, then probably we can discuss about it. Okay, let me move to the next one. Suicide is an impulsive act with no previous planning. Is it a myth or a fact? Dr. Mutua, you have unmuted yourself. You want to say something?
Yeah, I'll go with.
Sorry?
I'll say it's a myth.
It is a myth. Yes, it is a myth. People can plan for suicide over a period of time. So if you see any, as I mentioned earlier, most of the things that I'm mentioning can be independent topics. So if you in suicide, you can be educated on how to identify suicide. People who want to die by suicide, they plan over time. Some of them plan over time. Some of them it's just a decision that they have made that day, but they have been feeling like things are not working right, and so it is not something that happens just now. I'm sitting here and I'm thinking, no, I need to die by suicide, and I take an action. No, it's something that happens over time, and it is a planned thing. So as a person who attempts suicide will not try again, do you think that experience, like say for instance, some people try organophosphate poisoning, it was such an ugly experience, they felt so sick, they would never attempt suicide again. Is that true? Or is it a myth? Sally?
I would say it's not true. Actually, I think so. They tend to be more susceptible to commit it again.
Repeat suicide attempts are high. So an individual who attempts suicide, we have to take extreme care because chances of them trying again are higher. It doesn't mean that everyone who commits suicide will do it, who attempts suicide will do it again, but the chances are high that they will do it, and so we need to take them for psychotherapy so that they can take care of themselves. Suicidal people are actually mentally ill. That's a myth. It is a response to situations. So talking about mental health. I brought this up in case there are medical doctors or nurses who have appreciation of the neurotransmitters. And I believe all of us are aware of oh, sorry, I'm forgetting the word of, what is adrenaline and cortisol? Gosh, I think I'm now getting tired. We need to take a break. Hormones, yeah, that is the word. So ill mental health is usually affected by the main neurotransmitters that interfere or that are affected by an individual that are affected, that an individual experiences, is reduction in dopamine and serotonin, where this is a reward pathway where we feel good. So if we stop feeling good because possibly we have experienced a stressful situation, our dopamine levels are reduced. Our serotonin levels are reduced. The good feel experience is no longer there. And then also the hormones of adrenaline and cortisol are raised. And so you realize that the individual begins to have symptoms that, that can lead to ill mental health. So for instance, when we have high adrenaline, we usually say when somebody is anxious, they have high adrenaline level, right? So if we usually say that, I'm saying right because I'm hoping you're agreeing with me. So if we say that, then if this is constantly being released, the adrenaline levels are constantly high, then the individual will later possibly experience ill mental health if they are not if it's not addressed. So that high adrenaline level in the emergency services needs to be addressed, and we will mention some of the ways in which we can address them. So we all have mental health. Nobody does not have mental health. However, some of us may experience mental health problems. We've been around for about an hour, Dr. Mbuvi. Do you want to take a breather? Or do we continue? Seems like Dr. Mbuvi is not able to unmute themselves. Any team lead around who would advise us what you normally do after an hour? Any team lead? Sorry, I didn't ask that earlier.
No, it's okay. Okay, yeah, we can take a short break. Ideally, the discussion usually goes on. We do it from 9 till midday. And yes, we can't go like throughout completely. So what I'll suggest is, because now it's 10:13, I think we can take a 15-minute break and then we rejoin at 10:30.
Okay, thank you.
Is that okay with everyone? You don't need to log out, just stick around in the room and then we can, at 10:30, then Susan can come and continue the rest of the presentation. Because it's true, sometimes if you drag something for too long, it tends to become a bit boring and guys get a bit tired. So I'll just give you a few minutes. Yeah, chill kidogo, and then we come back to continue at 10:30. Is that okay with everyone? You can just unmute and say yes, no, let's have breakfast, I'm buying breakfast, blah, 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 anything like that.
Yes. That's fine.
Yeah, that's okay.
Okay, thanks guys. Okay, so just don't leave the group, just stick around, and then at 10:30, just take a short break, then we can.
Hi.
Hi guys. So we still have like 2 minutes left. So if you're drinking your tea, you can finish up. And then we can get to the next part of the presentation, which Susan will take us through what I'm currently sharing, which is the self-care and lifestyle balance inventory. Yeah, then we can see how things will go. Hello, everyone. Are guys back? Hello.
We're here, Doc.
Hi, Lynn. How are you?
Good.
Been a while.
Kabisa.
Yeah. Good to have you on board. Yay.
I miss the physical meetups.
I know. I hope
And the coffee.
Washira is hearing. Physical meetup.
And not forgetting the pizza dates after.
That's the thing. That's the thing. We need to do this. We need to do another physical one. We need to do another physical one. But we'll organize. Because now I'll be the one coordinating. So I will make sure we have a physical one with as much pizza than you can eat to carry home to Kimaliza.
Awesome.
Okay. So everyone else, I hope you guys are back. We are about to now to continue, and we'll go through the rest of the presentation, and then you'll have your question and answer sessions where guys can ask questions. And then if we exhaust all the questions, then we will call it a day. And then we will invite you for the next EM talks, which will be held at the end of this month, the last Saturday of the month. And this time we will be ready. We will have a presentation, we'll have a discussion, we'll figure out an interesting topic. And also, if there are any topics that you guys want to have in this Saturday talks, just kindly send them on the chat, which topics you want to be covered, anything that is interesting in regards to emergency care in Kenya or in the world, anything new, anything that you want to be discussed. We are happy to accommodate you. We are happy to accommodate any topics that you may have. So kindly hit me up on the chats. Let me know anything else that you want to be discussed in emergency care, and we will see how to accommodate. And now I'd like to ask our presenter, Susan, to continue the presentation. And we continue. And guys, keep your questions ready. Once we're done, we just have our question and answer sessions. And then we can call it a day, and I can release you guys to go ahead for your Saturday afternoon activities. Okay, Susan, you're welcome.
Thank you. I hope everyone has taken a good break. You enjoyed the health break and no one has dropped out. Okay, so let's move on. We were talking about some of the, let me go back, some of the manifestations that we observe in the workplace. As I mentioned, since we are not mental health specialists, we may not be able to identify that this is somebody with PTSD or this is somebody with depression. Why I brought this slide was just for us to know that it is a normal, I want to call it a normal illness. It's not an out-of-the-world illness. It's an illness that if one is diagnosed that they have anxiety disorder, it's an illness that needs treatment. So it's not an illness that we need to probably get somebody out of the force, or if somebody has PTSD, we have to terminate their services. No. That's why I brought this to our attention, so that in case you have ever been diagnosed or your colleague was diagnosed, please support them. Please provide provide the necessary support that you can to them, so that they can be able to be. Remember, we said mental health, well-being. One has to have what? Let me take an exercise with us. What is mental health well-being? Remember the WHO one. The slide on WHO. How do they define mental health well-being? Okay, let me bring it to us in case maybe we were still settling. I think it's this one. The person has realized their potential, cope with normal stress, normal stresses, be productive, and be able to contribute in the society or in the community. So if one has these illnesses, we do not want them to stop having all these symptoms. I mean, all these characteristics. We want them to be able to serve with us in the mental health, in the emergency services. Sorry about that. So then, as I was saying, you may not be able to make a diagnosis as an observer. You may not be able to make a diagnosis. But what are the things that you may see in your colleague, or or you experience as an individual, so that you can reach out for mental health care? So if an individual is unusually, is somebody speaking? Somebody wants to say something? Okay. So if you're experiencing any of the symptoms that I'm going to say and many others, Salim, do you want to say something? Or is it by mistake?
I wanted to ask something.
Okay. Salim, you may want to type. Kindly, if you're able to type, your network is not clear. Kindly, Salim.
Are you hearing?
Not too clear, or is it my side? Anyone could, Dr. Ambuvi, are you hearing him clearly so that you can repeat what he says?
No, unfortunately, it feels like his network is a bit, it's breaking up, so I wasn't able to pick. Salim, could you kindly just repeat and see? Maybe.
Hi, can you hear me now?
Yes, that's much better. That's much better.
Okay. I wanted to just point out to us if we are grouping mental illness as this broad spectrum, which also includes stress or PTSD or even burnout. Don't you think that last statement where we were saying either myth or true, it becomes a yes or no answer rather than a complete no, where we were saying suicidal people are actually mentally ill?
What do we think? Thank you, Salim, for that challenge. What do we think? Okay, in terms, let me respond so that we can move on. In terms of mental illness, in diagnosis, we do not have suicide as a diagnosis. It's a symptom of other things. So it is not mental illness. It is a symptom. That's where the trick is. Okay, Salim. So it's just about terms.
Oh, yeah, I get it.
Language.
Yes, it's a symptom of mental illness rather than, yes, thank you.
Yeah. Okay, so what do we feel or what do we see in other people that we need to bring to their attention or bring to the attention of our managers so that we can take care of the individual's mental health? So if somebody is irritable and highly sensitive, you say something, they have raised a concern about it. Say something you do, they're always irritable. That's what I would say. They are not happy with anything. They find the staircase has not been cleaned. They are making noise the whole day about it. They are not easy to deal with. So others are easily startled. Like the door is banged, they jump. The phone rings, they never have vibrate anymore on their phones because the phone just rings like that and the vibration just startles them. People who are, other examples is people who are productive in the workplace, you realize they begin to be not recognized, they don't speak in the meetings, they don't provide suggestions. Somebody who is always tired, they come to work in the afternoon, oh, I'm tired. They come after leave, the first day of work, they are tired. They are always tired. Another thing you may see is people taking sick leave often. Yes, there is mental illness that can lead to or even physical illness that can lead to sick leave. But you realize that that sick leave is too often that you're wondering, is it the medicine that is not working, the medication that they were prescribed for? Is it that they're not taking the medication, or is it that they're experiencing ill mental health, ill mental health that they can't perform appropriately? Other examples of ill health is sleep disruption. Does somebody sleep too much or too little? An individual gets into bed at midnight, by 3 they're already up. And they're up that they cannot sleep at all, but they have not rested. Even that 3 hours sleep was not sleep actually, they just lay in bed. Or somebody who is constantly in bed. So other things are aggression. Somebody who is always aggressive. They're always banging the ambulance granny. They're all, when they come to hand over a patient, they're quarreling with everybody. The healthcare worker in the emergency room is quarreling. The relatives quarreling. The colleagues quarrel. You know, they're always aggressive. And it's negative aggression. There is positive aggression that helps you to move on. But this particular aggression is negative aggression due to frustration. A person who rumination is constantly speaking negative. They never see anything good. Today, the weather, where I am, the weather is cold. So they are complaining about the cold weather. In the afternoon, it will be hot. They have a reason to complain about the hot weather. If it is BBI, if I could mention it, they are complaining about BBI. Mara, they are complaining about, everything to them is negative. Nothing can ever be positive or can ever move them to anywhere. So people who are isolated and withdrawn, individuals who do not want to get involved in activities like the last one, social activities. I had pizza being mentioned. I hope I'll be included. But anyway, I'm not, if I'm not included, it's okay, because probably I won't know, but I hope I'll be invited. But then now, if people who used to be volunteer and bring ideas about where we will go, where the new place is, they're not interested anymore. They always have a reason. Some people may have practical reasons, like say, for instance, maybe they have a seminar like today. If I was invited by friends this morning, I may not have joined. But then it may be withdraw, in fact, in terms of, I do not want to be with people. And I may not know, or you may not know, because I will always give an excuse. So as you see this happening among your colleagues, it's not like you're being nosy, but more of being concerned. Be able to differentiate. Are you being nosy, or are you being concerned about the person not involving themselves in social activities? And any of those examples, and many things, probably if I had allowed you to speak, you'd give examples of some of the things that you have seen in your colleagues. And so you want to ensure that if you observe this, once again, if it's in yourself, you've seen, there's something wrong that has happened. I'm usually, the way I've answered my colleague here, this is not normal. You can bring it to the attention of your colleague, or if you have a mental health provider, bring it to the attention of that person. Or if you observe it in somebody else, you can bring it to the attention if you're comfortable with them, or your manager, so that they can take action in terms of taking care of them, not dismissing them from the workforce. So what happens when we have these things? You realize that we have poor and difficult work environment, and we do not want to have that amongst ourselves. We want to ensure that when we get into the workplace, we are enjoying what we are doing. Many times we spend so much time in the workplace than anything else, because even if it is, you say that you're given a shift, your shift ends at 2 o'clock. that you will be home longer. No, because you're on the way going home. Then when you get home, you're not even dealing with your family. Probably if it's a woman who involves themselves in the home activities, they'll find themselves busy with the home activities, not the individual that is in the house, like maybe a partner or the children. In the evening, you're off, you've slept. So you didn't spend time with the people you're living with as much as you spend time with people you're working with. Because when you're working with people, if you're an ambulance provider, you're always maybe telling the driver, or you're maybe driving fast, or you're not taking care of the potholes and things like that. You're always in communication. So you want to ensure that your workplace is not bearable, is comfortable for you to work in. But the organization, first of all, has to also support us first. So we want to ensure that we improve the work ambience in terms of if you're able to control the noise that is in the environment that you work in, ensure that you can do that. These constant construct trolleys that are not running well, including even the sirens. Must you have the siren on? And let me distract myself a little and say, in terms of the siren, if you have a patient, for those who are in the pre-hospital environment, if you have a patient in the ambulance and your siren is on, what are you communicating to that patient? Possibly you're saying, this patient is terribly sick, we need to get them to a hospital. So what's going through the patient's mind? My time around here is almost ending, so I must be very sick. So their anxiety goes up, their fear goes up, everything goes up, and then interferes with the treatment and care. So you want to be very careful when you're using a siren when you have a patient inside. I know in Kenya it may be difficult, because if we don't make noise, people will not get out. But then you may want, when you're developing policies, and now that they're doing the issues about roads and all that, you want to participate in ensuring that we have better education to the motorists, where when we see an ambulance and the lights are on, we should allow them. We shouldn't only wait for them to put on the siren, because if there's a patient inside, then we are affecting the patient's well-being. That was a commercial break. Anyway, so organizations, we want to ensure that organizations sensitize individuals, and I'm very glad that you guys are here to just sensitize yourself about mental health. The education could be about reducing stigma, recognizing symptoms so that individuals do not get chronically ill that before we have identified them. In preparedness, sometimes that anxiety of not being ready to do something can cause somebody to can interfere with one's mental health being. So you want to ensure that you allow more practice. Issues about drills is okay if finances can allow. Simulations these days, we have a lot of this, so ensure that you participate in them so that you can reduce your anxiety. We need our managers to be aware, and so that they can support individuals. Establish programs like in KNH. I work in KNH for those who joined later, and we have a program we call EAP, Employee Assistance Program, where individuals should be free to walk into that center and receive mental health care. So in your organizations, you want to maybe raise this with your managers so that they can develop policies and programs that can help us, and those other issues that are written on their create mental health friendly environment and effective communication in our midst. So in the pre-hospital care, there's something we call critical incidence stress management. I'm not aware. The few times I have worked with the pre-hospital care individuals, we have not been keen on this. But in developed countries, it is compulsory that individuals go through critical incident stress management. Why? We had said that there is anxiety, there is stress, there is all those things, burnout, exposure to burnout. So we want to ensure that when people experience critical incidents, they are attended to, their mental health wellness is attended to ensure that they calm down, they are able to debrief so that they can not develop the mental health manifestations that we raised earlier. Some common ones are pre-incidence briefing, where it's before before an incident occurs. So it can help if we, the mental health people, are allowed to come in and brief individuals on some of the things that they may expect, so that when it happens, you can know what to do. There's also diffusing, there's critical incidents debriefing, loss and grief, and crisis management. All these are usually to develop resilience so that we are able to successfully continue with our work and be aware of what is happening within ourselves, in case it's more of like an educational session where we also raise awareness of some of the things that you may see, so that if you feel that or you see that in yourself, you can bring it up with your mental health provider. So other things that we can do in the emergency care environment is psychotherapy. Psychotherapy is active psychological management, where individuals are challenged or assisted to ensure that they deal with their negative, usually to deal with their negative perception, so that they can be able to be productive in the workplace. Other common ones that are coming in around is EMDR. EMDR is eye movement desensitization and reprocessing. The other one is TRE, is tension, stress, trauma, releasing exercises. So these two, what they do, they deal specifically with trauma. And like for the tension releasing exercise, the example I would give is that when we experience a scaring environment, what do we normally do? There is fear, flight, freeze, or the other one is what? Anyone? Freeze, flight, or freeze. Okay, so what happens, like say for instance, if we freeze, those chemicals that make us to freeze do not get released. They stay within the body. And so when they stay within the body, with time we start having the hapa syndrome, if I could put it that way in Swahili. So you realize that the person is always having a back pain, but
Susan?
Yes, sir.
Hello?
Yes, Dr. Mutua?
Yeah, it seems like you are breaking up a bit. Or was it just on my end? Anyone else got her clearly, the last few statements?
Okay.
I can get you clearly now, so you can just continue. It's okay.
All right. So I was saying about the last example I was giving. I don't know when I stopped because it didn't show on my side. So tension is usually the TRE is tension, stress, trauma, releasing exercises. So I'd given an example of when we go through an anxiety situation, the chemicals stay within us. So later the individual has headache, but they're not understanding where the headache is coming from, or a backache, or you feel uncomfortable. So TRE helps to release those chemicals so that the individual can stop having those symptoms. Sometimes, as I had mentioned earlier, PTSD, depression, anxiety disorders are disorders that may require psychiatric care, and so ensure that individuals are taken for psychiatric care. So now individual responsibility. These previous ones are organizational. You have to be released to go for psychotherapy. The organization has to bring in programs where they allow CISM to take place. Organization has to ensure that they create a mental health friendly environment. But now about an individual, what can you do? Look at this picture that is there for those who may be able to see the picture. How often do we allow the battery to go down? Anyone? Or do we ever allow it to happen? Is that question? Never, actually, almost never. But yet, we allow ourselves as mental health and as emergency care providers to get drained. And how do we do that? Let's do this questionnaire. Dr. Mbuvi, probably we can share the questionnaire. We had shared the questionnaire during the break. For those who had tried to do it, it's okay. Continue doing it. So the next questionnaire, I would allow, yes, thank you, Dr. Mbuvi. Okay. Let's go through this questionnaire on our own. Try and fill it as honestly as possible. Let's see how much do we take care of ourselves. If possible, let's all complete this questionnaire. I'm not going to ask the answers. I just want us to know our current situation so that if we find they are low, you personally need to put on the charger, as we have seen in the previous slide. If you're doing well, then maintain what you're doing. So let's go through this questionnaire on our own and see how good we are. Don't think too much about it. Just answer as fast as you can. We will allow maybe maximum of 5 minutes for those who may be reading slowly. Okay. Kwa nini hii nini haina sauti? Nataka 20 bob. Kama wewe ndio kukosa 20 bob hai. Julie, jaza questionnaire kwanza.
Hi.
Yes, Grace.
Hi.
Hi, please complete the questionnaire.
I'm trying.
Okay, great. So if whatever you do is almost never, put a 0 on it. If seldom, like it's once in a blue moon, put 1. If it is sometimes, like once every 2 months, or just when you're reminded, like today, you can put sometimes. Often is that it is frequent, you are conscious about it, and so you do it. And then there is the 4th one, which is almost. Almost is you do it regularly, as in it's part of your lifestyle. So put any of those figures, 0, 1, 2, 3, or 4. Then you add them up once you have completed. So if anyone may have missed, we are filling this questionnaire. So you can fill in the answers on a piece of paper, or if you are not using your phone to see the notes, you can add the addition. Like if question 1 was I have at least 1 full week off weekly. So if mine is 4, I'll put 4 plus the next one. If it's 0 plus 0 plus 1, like that. So I hope I have responded appropriately. So we should be finishing in 2 minutes time. And even if you don't finish, it is okay. I believe Dr. Mbuvi will share with you later. But just for us to have an idea of what is happening.
I don't know if it is just me, but on the slide from number 11, I'm not seeing 12 to 15. It goes to 16.
Oh, yeah. 1 second. Let me look at. Just continue to 16. I confirm what might have happened. Okay. Yeah, I realize a portion has been cut out from 11, and then from 26. We don't have 27 and 28. Thank you.
Okay.
Thank you, Dr. Ray.
Welcome.
The problem is if I reduce the screen size to get all the numbers in, I don't know, is everyone able to see the post, because they're very small. The print is very fine. Is everyone able to like read through the numbers, especially the ones which were out from number 12, 13, 14, and 15, and then 27?
Yes, now I can see them.
You can see them and you can read them.
Great.
Yeah, by straining a bit, but yeah.
Okay.
Sorry about that.
If I make it any larger, they disappear. So let me see. Let me just try. Maybe make it a bit more.
So we have just maybe a few seconds to proceed. So as we complete that, if your total, because you should get, if everything is 4, it should be 4 times 28. You all answers were 4. Should be maybe about 110 or 12 thereabout. So if you got above 94, if you got above 94, congratulations in terms of how you are taking care of yourself, and possibly you need to continue doing it, because reducing it would you would not be well prepared for high stress. So whatever activities you're doing, ensure that you you continue doing it. If you can even coach other people on doing the same, it would be good, because we are each other's keeper. So if you have between 60 and 94, you have an idea of self-care. So all you need to do is probably improve on the strategies that you put in place, so that you can be able to be ready for high stress. If you do not engage in activities that improve your self-care level, then when you have high stress, you will experience anxiety. You will probably experience other symptoms that we had scored. I want to believe nobody scored under 30, or no one will score under 30. If you have scored under 30, please actively engage in self-care and lifestyle balance, and we will see some of the things that we will do. Those who are at between 30 and
Lenny, see me, 1.5.
Okay, so those who scored between 30 and 60, your knowledge of self-care is a little average. It's average, actually. So please develop a plan on improving your self-care. So Dr. Mbuvi, we can proceed.
Yes, I've sent it in the chat. So guys can just go to the chat box and you'll find the image there. You can download it so that you can use it at your own time and see how your score will be like. And Susan has told us what the things that you need to do. Okay, so
so we move on to some of the self-care. We are almost finishing. We should be completing in a short while.
It's okay. You can share your screen now.
Sorry, we closed. Sorry.
It's okay.
Okay, so ABCs of self-care. We are good at abbreviations in the healthcare section, so I tried to develop some ABCs of self-care.
You can't see your presentation.
You can't see. Oops, sorry.
It's okay. Yeah, not shared it.
1 second.
Yeah, that's good. Now you can see it.
Sorry, and thank you about that. So we are good at abbreviations, as I had mentioned earlier. So I've tried to put all the things there. And like I said earlier, every slide I share can be a complete CME on its own, or it can be a complete session on its own. So I try to put in everything together so that we can have an idea, since it's bringing awareness. And then later, those that you may need further clarification or further discussion, then you can invite anyone from the mental health field, and we will come and possibly have sessions with you. So I've tried to bring in everything about self-care. So first is awareness. You need to be aware of yourself, your body. What is it that you don't like? What is it that you like? What is it that helps you? What is it that doesn't help you? So that you can develop a routine or a plan on how you can take care of yourself. Take breaks seriously. You know, these tea breaks that we take, and you go and you're spending time on your cell phone or spending time sorting out issues. No, take a break, even if it is 10 minutes. There's a word we normally say, power break. If it is, power nap. If you're taking that power nap, make sure you just rest, because it helps you to move on from a mental health perspective. Take vacations. It doesn't have to be expensive vacations. Just being away from the normal environment and not going to farm, not going to finish your building at a place where you're building. You want to take a break from everything. Do not engage yourself with any activity. Just let your brain rejuvenate. Spiritual support is very important. Maintain contact with people. Communicate what you're feeling so that people can understand you, and possibly raise awareness to issues that you may need help, or even people will understand what you don't like. And in not liking, when somebody expresses themselves, sometimes we find ourselves doing forced desensitization. If somebody does not like something, we expose them further to that thing that they don't like. It is not right. And possibly that's why when people don't disclose themselves, and when they don't disclose what is going through their mind, then they get stressed, because now they're being exposed to something, but they don't like it, and they can't tell, because if we tell, then we will be further exposed to it. So kindly, when somebody discloses something, like say for instance, if you know that people do not enjoy, like for me, I don't like morning activity. So if you give me morning activities, just because you know that I don't like morning activities, you want me to be like everyone else, you're not being fair to me. While probably if you allow me to work up to late in the night, I will be more productive. So if you are able to adjust your activity, it's not a must, but if it is possible for you to adjust, ensure you adjust to allow people to be optimum in their production of their performance. There is deep breathing exercises and stress relieving exercises. We must eat healthy. I know pizza was mentioned. I have to mention this pizza several times so that I'm remembered. Anyway, we can eat the pizza, but let's eat healthy. Ensure we are eating enough vegetables, enough fruits, less carbohydrates, as the nutritionist would advise. Drink a lot of water. Drink water. Don't forget water. I'm glad people are lately around, we are carrying around the bottles, but we finish that bottle of water? That's a question I would want to pose to you. When you carry that 2-liter bottle of water, do you finish that water? So ensure that you take enough water, clean water if possible. Be grateful of the circumstances that you are in. Yes, maybe your patient, unfortunately, may have died in the ambulance. Be grateful that you have that job. Don't concentrate so much on the patient you lost. Be grateful of things that are happening. Be grateful that you have maybe you have a child. Somebody else doesn't have a child. Be grateful that you live in Nairobi. Somebody else in Marsabit is hoping that they can land down and come to Nairobi. Look for something to be grateful about. There must be something. So make sure that you look around and help your mind by being grateful. So because of time, now just not allowed too much discussion. There are just a few more slides that are left. So why is it that we don't take care of mental health? Why is it that if I am mentally ill, if I have depression? Why will I not seek help? Why will I not, like Dr. Mbuvi is my boss? Why don't I talk to him? Why don't I disclose to him that I am mentally, I have a mental health issue? Or if I have, I need to be assisted in the employee assistance program, why can't I be comfortable to tell Dr. Mbuvi that, Dr. Mbuvi, tomorrow kindly give me my off day, I will be going to mental health. If you hear me say that as my boss, not Dr. Mbuvi as himself, but you as my boss, if you hear me saying that, you as my colleague, if you hear me saying that, tomorrow, by the way we normally say, kesho naenda kuchukua mtoto shule, it's very comfortable to say that. How often do we say I'm going for a psychiatric review? How often do we say I want to go and see the psychologist? Many times we hide. Why do we hide stigma? Sometimes people can't see what is it that this person is going to seek from a psychologist. It's not visible. It's not obvious that somebody has a mental health issue. So we may not be able to allow them, or we mock them when they say that they want to seek help. Sometimes it's even administrators and managers. They don't understand. All they need is figures, numbers, results. Mental health is not part of it. So we need to raise awareness. Now, this story about the pair of a pair who are camping. I'll give you the story. And there were two people. They went camping, and in the middle of the night, one of them woke up. And waking up, they looked up, and they saw what they saw, and then nudged the other person next to them and told them, hello, can you see what's happening? And the person says, I see stars, I see the moon, I see a beautiful galaxy. The other one got so offended and said, oh, you fool. Excuse me. Our tent has been stolen. So which person are you? Are you the person who is able to recognize the things that are around you? How do you interpret things around you? And are you the person who will insult people around and bring to the attention of people on the negative things? Because if you've woken up in the middle of the night and the tent has been stolen, chances are you would have been feeling cold. How come you're not feeling cold? Animals would have chewed you up. How come animals had not harmed you? Chances are you're in a safe environment. So why see the negative rather than the positive? So that's what I'm bringing to our attention, but also that we all interpret issues differently. Yes, of course, the galaxy, the stars, the moon are beautiful to look at, but our tent has been stolen. So we interpret things differently. This tent that has been stolen, we had it because we needed it. It's not like we didn't need it. So we interpret things differently. So what do we do if we expose us when we are working together? What should we do? We should have emotional intelligence so that we are able to understand ourselves and understand the society around us. So understanding ourselves, some people would call self-awareness and self-management personal competency, and social awareness and social management as social competencies. So self-awareness, personal competency, how competent are you with yourself? How competent are you with your emotions? Are you confident? Are you aware of the impact of your personal emotions on other people? And are you aware of how the emotions of other people affect you? Then in terms of management, are you able to adapt to circumstances? Or are you do stick to one thing? You cannot look side left, you cannot adjust. And then in social competencies, how empathetic are you to people? How do you, somebody had mentioned they are good at reading people's moods. When you read the individual's mood, are you able to respond appropriately, or do you use it against the individual? Or do you just hear and it is over? Do you relate with people well? Do you inspire people? Do you create teams that work, or do you divide and separate people? That is emotional intelligence. When we have high emotional intelligence, we'll be able to develop proper care for one another, for ourselves, because we get to understand ourselves, but also we are able to deal with each other appropriately. I have a clip that I would want to play here.
Check this out. This could be the most important video you see today. Imagine that this rice represents the population of the world. The brown rice represents those people who will never experience a mental health problem. And the wild rice represents the 1 in 4 of us who will at some point in our lifetime experience a mental health problem. Let's just mix that up. Now, when you have a mental health problem, your mind convinces you that you are the only one. But let's just take a pinch. That represents your family. This one's your friends and some work colleagues. It's a natural part of being human. So whether you're with your family, your friends, or your colleagues, likelihood is a few of those people at some point in their lives are also going to struggle with their mental health. So even if you're not struggling, the chances are you're going to brush shoulders with someone who is. So be kind. Like this. This could be the...
Okay, she's speaking fast, but I want to replay it again and probably request one of us to repeat what she may have said kindly. So I'm playing now so that we can listen more carefully and then request any of us to, or several of us to respond to it. So I'm playing it once again.
This could be the most important video you see today. I want you to imagine that this rice represents the population of the world. The brown rice represents those people who will never experience a mental health problem. And the wild rice represents the 1 in 4 of us who will at some point in our lifetime experience a mental health problem. Let's just mix that up. Now, when you have a mental health problem, your mind convinces you that you are the only one. But let's just take a pinch. That represents your family. This one's your friends and some work colleagues. It's a natural part of being human. So whether you're with your family, your friends, or your colleagues, likelihood is a few of those people at some point in their lives are also going to struggle with their mental health. So even if you're not struggling, the chances are you're going to brush shoulders with someone who is. So be kind. Like this.
Okay. Somebody just repeat for us in case it wasn't clear for all of us.
I think basically she was saying that in any environment that you're in, when you have a mental health issue, you always think that you're alone and that it's only you who's suffering and no one else understands what you're going through and no one else knows what you're going through. But in reality, you find that whether it's your family, your friends, or your colleagues, there's always someone who has also experienced a mental health problem, someone who may also be able to, who understands what you're going through because they have gone through it or they are currently going through it. So you should never think that you're alone. And I think the main parting shot of this is that if you feel you're overwhelmed, get help.
Thank you, Doc. So we have come to the stage where I finish my presentation. So open to questions. Concerns, comments, questions?
Okay, guys, anyone who has a question can just unmute and ask your questions. Susan is here to answer them. And yeah, so we are waiting for your questions. Yay.
As we wait for the questions, is Dr. Mareko with us? I don't see a name close to him. Dr. Mareko, did you join? Or Nelly or Pio? Those are colleagues I had requested to come and join me. Nelly, any comment?
Yes,
I'm here.
Great, Nelly. Is there something you'd like to add as we get questions, in case we have any?
Actually, Susan, I think you've done justice to the topic. What I just encourage the rest of us is just the way we have physical illness, mental health illness is there. And we need to actually, she's told us the telltale signs, and please let's seek for help, because help is out there. Thank you.
Thank you, Nelly. Mr. Michel, are you here? Probably not. I don't see a name close to Michel. So, any questions as I complete?
Yeah, guys, you can just open up, just unmute and ask your questions in regards to mental health for us as emergency workers. There's been a lot of gems that have been discussed today by our presenter, Susan. And I think the one which sticks out to me the most is the fact that we should not be afraid of mental illness. We should actually embrace our colleagues or anyone who may be undergoing mental illness, and the fact that it's up to us to stop the stigma. Basically, like she said, if you are the head of a unit or you're the boss, and one of the people or your colleagues comes and tells you that, yeah, you know, I need a day off because I have some mental health issues that I need to go and sort, you should be empathetic to them and actually be able to provide this space and opportunity for them to actually do that. And once we begin to create that environment amongst ourselves and amongst our colleagues, we end up fostering very good, we foster good working relations, and we also build on the trust that we have. And I know for majority of the people who work in the emergency department, we know that for us, the main thing is the trust that we have. Because if I can trust my colleague and we're working together and we know that we can actually save the patients who come to us, then we're actually striving towards making things better. Yeah, so anyone with a comment, suggestion or anything like that, kindly unmute and you can let us know. And in the meantime, if you can check the chat box, there's a Google form I've posted there. It's mostly for, it's our feedback form for this EM talks. And I'd like to get your views on that, so to see how we can make this better and how, or like I said, there's a part where you can add and tell us if there are any other topics that you want to be discussed in regards to emergency care. Thank you. So anyone who's ready can just take the floor, and then we can ask your question or give your comment, even just a comment about how the presentation was, what are your take-home points and things like that. Kindly. Thank you.
Hello, everyone.
Hi.
Yes, hi, David.
Yeah, sorry I left you guys a bit. I was a bit involved somewhere. So maybe I might have not heard everything you guys went through. I'm a mental health nurse myself. So I wanted to ask something. If you guys can bring about issue to do with MHGAP HIG training, which is a training mostly involving people, non-professionals, which actually can help a lot in an emergency setup. Thank you.
What did you call it, David? I'm sorry. Dr. Mube, did you get the training?
David, could you just kindly repeat that? What was the training? And then maybe you can just expound a bit on it for like just 2 minutes and just let us know what it's about and how do you think it can help? That will it will help us now be able to plan and see what we can do about that.
Oh, you want me to clarify about it, huh?
Mm-hmm. Yes, please.
Mental health, it's a mental health gap program. It's a program which mostly involves a few of the conditions of mental health, such as epilepsy, psychosis, OTH. We have depression. We have suicide. There are like 7 cases. And also how to diagnose some of these cases through some few assessments. There's a module. Actually you can check it through the WHO. link. It's called MHGAP HIG version. There is version 2.2 something. You can check it there. It contains a lot and it's very good. It's very summarized. Actually, HIG is a summarized form of MHGAP. That's why I was like, any person who is not a mental health practitioner can actually go through it and understand it the quickest way possible. Yeah.
Okay, David, thank you for that. That's very good information. I think we can get in touch after this and see how we can work on that, because it sounds like it's something very interesting. And if it's something that can help even people who are not healthcare practitioners to understand the concepts of mental health, that I think that will help. Some of the conditions you've mentioned, like epilepsy, these are conditions which these patients come in with conditions like status epilepticus into emergency departments, and being able to understand from which point they come from, and also if their relatives and the person who's taking care of them also understands this, then it would actually be a good thing. Yeah, thank you so much for that suggestion. I'll look into it. I'll check the WHO references that you've given, and then you can see what you can do about it. Thank you, David. Anyone else?
Thank you.
Okay, anyone else with a comment, suggestion, a way forward? Because we're almost at the end of our, we've come to the end of the presentation. So now it's just basically question and answer session, or just giving out your comments and things like that. So I'll give a few minutes for anyone who may be willing to talk, say something. And if we don't have anyone, then I think we'll just we'll call the end of this open mic session, and we look forward to the next one. So anyone, comments, briefs, anything, even just saying thank you to Susan for such a wonderful presentation. We've learned a lot, but yeah, I know someone can just give her a word of encouragement. Thank you so much, Susan, for that presentation. It's been very nice.
Thank you.
Hi, and I can reiterate that also. It's been quite a good interactive and good session. We've learned a lot. We've got quite some progress in it. For you, I've seen the questionnaire and I filled it, but I've not seen the form for feedback, but I've not seen the questionnaire in the chat group. If you can send it so that we can also use it for our other colleagues in other sessions. Thank you.
Thank you.
Hi, Susan and the rest of my colleagues.
Hi.
Hi, thank you very much for the session. Sometimes we pick out our colleagues behaving in a funny manner and you're thinking, what's wrong with this one? And you start stereotyping them. So with that knowledge at the background, then you'll be able to pick out maybe people who are going through depression or some post-traumatic situations, and you'll be able to help. So thank you very much. It's also very encouraging to know that our colleagues in other professions are thriving in other areas in a very nice way. Well done. And we really appreciate it.
Thank you. So maybe I can close by saying thank you very much for this opportunity. It was a privilege and I cannot take it for granted. So I thank God first for the ability to know some things on mental health, like Prof, sorry, but soon you'll be a Prof Doc. Dr. Dr. Mumi said, currently I'm in mental health care. So I can't take it for granted that the Lord allowed me to know about mental health. So thank you for this opportunity to speak with you and have an interaction with you. I pray that I have raised some antennas, that you will have more sessions with mental health specialists. I hope we will invite more sessions with the mental health field, not necessarily me, but anyone in the mental health field, so that we can be able to understand our patients, but also understand one another in the as we work together, as we are in the workplace. Thank you once again for this privilege. I want to appreciate Nelly. I'm not sure that Dr. Mareko joined. Thank you for offering to join, Mr. Michelle for accepting the invitation, and Ms. Nelly for agreeing to even speak. Thank you very much, everyone. Bye-bye.
Okay, thank you so much, Susan. We really appreciate. We had a wonderful session. Thank you so much. To the rest of the team, for the guys who joined in, for the questions, the guys who gave their comments, much appreciation from my end. Thank you so much for joining us on this session. This session has been recorded. We'll see how to send the stream to you guys, and then you can be able to go back and see the things that we have discussed and what take-home things you can, some of the things that you can take and back to your places of work to see how we can continue to champion for a good mental health in the emergency department and in emergency care. And like Susan had said, there's a lot of things, like every single slide is a topic on its own. So if there's anything that you may want to be discussed, let us know. You can reach us through all our social media platforms. We are on Facebook, we are on Instagram, we are on Twitter. We are yet to join TikTok. We're still trying to figure out how it works. But once we do, yeah, trust me, we will be there on TikTok, kabisa. Anyway, I want to wish you guys a very, very good Saturday afternoon. Go and enjoy yourselves. Thank you so much for joining us. Looking forward to the next EM Care Talks open mic session. As I said, my name is Mbuvi Mutua, and I am the coordinator for EMKF in regards to the emergency care talks. Thank you, and thank you once again.
Thank you very much.
Thank you.
Thank you, bye.